apologise for that delay. We just have one of our presenters who's having trouble with the link, so we will come back to that. So welcome everybody. I'm really pleased to be hosting this session. You can see that today we're going to be talking about this really important issue of marijuana legalization, and we're going to be talking about some of the harms and the potential responses. So I welcome you on behalf of the International Committee for the Society for Prevention Research. And this is part of an exciting online meeting that we're having. And you'll see that we've got some very interesting discussions we're going to have. We have a talk from Stuart Reece, who's with the University of Western Australia. He will be walking us through a causal analysis of where he's used very big data looking at some of the harms of marijuana legalization. We then have Julian Santaella-Tenorio, who will talk about legalization and vehicle fatalities. If Stuart has some trouble getting on, he's had a little bit of trouble this morning, I will begin with Julian. We're then going to have a case study from Jen Bailey from the University of Washington, who's going to be talking to us about Washington State and some of the experience there. We're then going to pivot to talk a bit more about opportunities for prevention advocacy in prevention science. And so we're very pleased to have Kevin Sabet, who will talk to us about the experience with SAM, and that's the Smart Approaches to Marijuana. And so he will tell us more about his advocacy organisation and the work he's doing there. And then Shane Varcoe from Australia, from the Dalgarno Institute, will talk to us about work he has done in terms of trying to address this issue in Australia. So at this point, Stuart is with us, so welcome, Stuart. And I will welcome you, Stuart, to share your presentation and turn on your video. And we look forward to hearing from you. Now, I think you may still be on mute, Stuart. Need you to, your microphone's not working, Stuart.
Start video. Press start video.
Great, we've got you. We've got you now.
Oh, great. Oh, good. Okay.
Yeah, thank you.
All right. So cannabinoid neurotoxicity and genotoxicity. Let's talk about the power insights in this, the geospatial and causal inferential analysis. Cannabinoid neurotoxicity and genotoxicity are causally established in autism, exponential growth. It's cannabis-driven mental illness, young adults, cannabis-driven, 44 of 62 birth defects in the US, 19 of 34 cancers, including breast cancer. Let's talk about neurotoxicity. This is the hippocampal gyrus, where the baby stem cells are born, the neuroblasts, the neural stem cells, the subdentate gyrus. These ones form the memory. Cannabis impairs neuroblast formation. This is the synapse, the basic machinery of the synapse. Neurexin and neuroligin form the synaptic scaffold, and these are reduced with cannabis, which reduces your memory, ability to form memories. They're also involved in the formation of motor circuits in the early brain. The plasticity is published in Nature. And cannabis also disconnects the white matter connections in the brain. Mental illness, it's also linked with mental illness. This is a reference to a paper we published recently on this. In young adults, it's cannabis-driven. Now, this was the slides of Eleanor McCants Katz, director of SAMHSA, in her 2018 look at the 2017 NISDA data. It's fascinating data. It shows a drop in all the drug use in right across the US, but a rise in all the indices of mental illness and a rise in cannabis. All the other substances are dropping, so that indicts cannabis. This is space-time progression of tobacco, alcohol, cannabis, and cocaine use across the US at the sub-state level. You can see there's this heavy concentration in the northeast, the northwest, and in the center in Colorado. This is any mental illness, serious mental illness, suicidality, and major depressive illness here. And again, you can see the northeast, northwest, and central concentration. So looking at the causal inference, these inverse probability robust models, and you can see cannabis is highly significant here. And the inverse probability makes it a causal model. You can look at geospatial models. Again, the regression coefficients are positive, and the overall direction of these models is positive. So you can calculate E-values. E-values is a way of looking at the confounding and the causal relationships. The higher the E-value, the more likely it is to be causal, and a lot of these E-values are quite high. See 10 to the 5, 10 to the 6 is very high. So this is autism. These are our papers on autism. Exponential growth, cannabis-driven across the US. You can see the exponential growth in autism in the US, and you can project it out, medium-term projections. This work's been published, and it's very different by criminal status, decriminalised, illegal, and legal. This is drug use, cannabis use across the US by age group. And as you can see, it goes up a little bit here in the 26 to 34-year-olds. But what's really gone up 2.1-fold, as you'll hear in a minute from the other speakers, is daily use. Daily, near daily use has really gone up. And again, you can do causal inference on this. This is a mixed effects, inverse probability weighted. And again, it's highly significant. These models are positive. The coefficients are strongly highly significant, 10 to minus 10 to the 4, 10 to the 21. You do E-values on these, as you can see, and these E-values are very high in dieting cannabis. Let's talk about genotoxicity, which is mechanisms of genetic damage from cannabis. So we're talking about genotoxicity. At anaphase, when the cells divide, the chromosomes slide along the mitotic spindles. These are made of microtubules, which is polymerized tubulin, as you can see here. And at the growing ends, the plus ends, the cannabis inhibits tubulin formation. So it causes the chromosomes to slide off the ends and get chromosomal polarization. It's genetic junk. Often kills the cells, but it can cause birth defects, mental retardation, and cancer. For 50 years, it's been known that cannabis reduces histone formation. The DNA is wound around histones, so that as the histones decline, the DNA necessarily opens up, and it grossly dysregulates genetic expression. This is a change in DNA methylation in sperm. You can see there's a major change in DNA methylation here, both hyper and hypomethylated. This also dysregulates genetic information, especially the hypo change, which is quite toxic. Now, mitochondria generate the energy in the cell, which is very involved in genetic and epigenetic reactions. This is the F1-ATPase, the generator that spins, it actually makes the ATP. Cannabis reduces the synthesis of the F1-ATPase. And this is showing THC and cannabidiol as the drug increases in the micromolar range. You can see this dramatic, abrupt asymptotic log drop in the energy charge in the mitochondria, which also occurs with aging here. So the cannabis is phenotyping and aging, phenotyping the mitochondrial energy charge. And as you can see here, this is reflecting a high death rate in long-term cannabis addicts. That's a Swedish study. There's a nonlinear dose response that's really important. As the dose increases, this asymptotic dramatic drops that you get is seen in dozens of genotoxic and metabolic studies of cannabis. Here's a micronucleus formation assay. Cannabis is increasing in the micromolar range. There's a steep drop, steep jump. Let's talk about birth defects. Consistent observations found in 5 regions: Hawaii, Colorado, Canada, Australia, and the US. 44 of 62 birth defects arisen in the US. This is sperm this is normal human sperm. And as you can see here, this is a human sperm on cannabis. These are grossly deformed heads. And some of these sperm have 3 or 4 heads, 4 or 5 tails, bent tails. There's a pus cell there in the middle. And this is a grossly inflamed site, which is also a genotoxic change. Now, this is the paradigm shifting study, 2007, from Hawaii, looking at 21 birth defects showing they were elevated after prenatal cannabis exposure, with odds ratios from 5 to 40-fold, with a confidence interval up to 120. And there's serious defects on here. Arm defects is here, cleft lip, atrial septal defect. This is some of the defects we're talking about. Anencephaly, there's 2 CDC papers saying that anencephaly is elevated after, there's no brain, after cannabis. Cyanotic heart disease, as you can see. This is gastroschisis. All 7 papers looking at this have found a positive finding of gastroschisis, and the liver can come out, twist, kill the baby. And then there's serious birth defects here, as you can see, this phocomelia, missing an arm. This is Colorado over the decade of liberalization, 30% jump in birth defects. This is Australia in the high cannabis rate. There's 30 birth defects here, and 20 are 5-fold elevated in the high cannabis region. This is THC related, not THC related birth defects. It's a common, intermediate, and rare. In the common ones, you can see this is the rest of Queensland, this is northern New South Wales, Nimbin area. There's great separation between the confidence intervals, same sort of thing, intermediate. With the rare ones, there's overlap, but it's at the bottom end of the confidence interval. This is a Canadian study of gastroschisis. The bivariate relationship was 9-fold higher rate of gastroschisis amongst cannabis users, and after full adjustment, it's 3.5-fold. Let's look at the US epidemiology of birth defects. We just take one example, which is anotia or microtia, small ears, as you can see, different grades of it there. This is a space-time distribution across space and time. This big jump between the 4th and 5th quintile, the quintiles is the 20% divisions of cannabis use. The cannabis jumps dramatically, and over time, the 5th quintile is greatly elevated. If you look at causal inference here, you can see that these coefficients are positive. And these two models here, the sum of the matrix multiplication cannabinoid coefficients are positive, showing that as the cannabis rises, the effect in these models are positive. So that's an index that you can judge the overall effect of the model generically. So you can do your modeling. These are per miles, which are like percentiles, but there's 1,000 of them. And as you can see, at the top end of the range, it dramatically increases, reflecting in epidemiology what we see in vitro. This is an exponential model, so you take the exponent of that, and you get this sharp jump here, as you can see. This is the E-values from anotia. Now, more than 1.25 is thought to be causal. As you can see, the 49 of these E-values are all more than 1.25. The relationship between, everyone knows about the link between tobacco and lung cancer, and that's a 9-fold elevation. So 46 of these birth defects are more than 9, and 9 is very high, actually. And these, as you can see, is 10 to the 11, and two are infinite. Let's talk about the bivariate. There's 62 birth defects. This is the birth defects as a function of cannabis use. You can see they're rising. And when you account the early termination of pregnancy for anomaly, that effect is even more increased. So you can look at the birth defects here as a function of tobacco, and you see a lot of them are rising. We know tobacco is bad for you when you're pregnant. It's not recommended by ACOG. And again, with cannabis, you can see there's a positive effect here. And then these are the E-values. This is tobacco. This is binge alcohol. That's monthly alcohol, cannabidiol, cannabis, and THC, the E-values. So there's about 36 of them here for cannabis and 9 of them here for cannabidiol, but the amplitude is much higher. It's 10 to the 30. And again, so you can see that E-values comparative there. This is so with that technique, you can separate cannabis related and cannabis not related. You can see they're very different as a function of cannabis use. ETOPFA expands that difference. This is the number of congenital anomalies that are linked, that have elevated minimum E-values. Here's alcoholism. There's monthly alcohol use. There's tobacco, 2, 5, and 11 birth defects. And cannabidiol is in intermediate position. It's got 9. Tetrahydrocannabivarin, cannabichromene, cannabigerol, THC, cannabis, and cannabinol have 30 to 36 defects related. And when you add up the exponents of those E-values for alcohol monthly, alcoholism, and tobacco, you've got 0, 2, and 8 defects related there. So THC, cannabidiol, cannabis, cannabinol, so you add them up and they're very high, much higher than alcohol and tobacco, which are known. You can look at the extreme quintiles, the highest and lowest quintiles. You see there's a big jump between a lot of these quintiles. And from that, you can calculate E-values and attributable fraction and exposed. And the E-values on this series, remember that the tobacco lung cancer E-value is 9, so 78% are more than 10, 70% more than 1,000, 65% more than a million, 60% more than a billion, and 26% are infinite. And this is the E-values that are infinite. 80% are infinite there, as you can see. And that's the number there. So looking at geospatial analysis, these 38 defects are related on E-value. This is the geospatial analysis. Don't have time. Look at thalidomide. 21 of the 31 defects described in thalidomide are also seen in cannabis, and 12 of the 13 mechanisms. And legalization has a big effect, as you can see. Let's talk about cancer. These are the cancers in the cannabis literature that are linked with cannabis. 19 to 34 cancers on this one. US epidemiology of cancer. This is the relationship of cancer with increasing tobacco. You can see there's a strong relationship. The lung cancer, cervical cancer, oral cancer, prostate, vulva, vaginal, ovary, all these cancers are known to be related to tobacco. So here's the relationship with THC. Again, it's strongly positive. Here's cannabidiol. You can see some of these cancers are strongly positive. Let's look at breast cancer, space-time distribution of breast cancer across the US. It rises with cannabis and cocaine exposure and all the cannabinoids. And there's a big quintile effect here, as you can see over time. And when you dichotomize, again, there's a big difference. Legal status makes a big difference here. These notches on these box plots don't overlap. Dichotomize, you can see there's a big difference both in aggregate and over time. This is a matrix of scatter plots. This is the breast cancer rate here, and these are the cannabinoids down here. You can see the positive effect here. This is a call plot correlogram. These are the Pearson correlation coefficients and their significance and stars. Look at the models, these different cancers, different space-time models, and most of them are rising, and they all, nearly all have this sharp jump at the top. In some cases, it's quite high, and then in some of them it's dropping. And this just shows that the cubic model fits this much better than the line. That's the log of the p-values, the ANOVA test between the cubic and the linear change. These are the p-e values from the polynomials. You can see this is the exponent, and you can see it's very high for all these different defects. Now, this compares the numbers. This is assuming an etiological fraction of 1 here, etiological fraction, which is trivial fraction exposed, etiological fraction, trivial fraction in the population. There's cigarettes, alcoholism, and obesity are here. Medical cannabis, cannabis quintiles, liberal cannabis, decriminalized cannabis are here. So you can see that no matter which trivial fraction you use, the cannabinoids are at the top, and there's cigarettes and obesity there, but in most cases, the cannabis is very responsive. This is cannabidiol, assuming an etiological fraction of 1. These are the p-values, these are the case numbers. So if the etiological fraction is 1, cannabidiol would be implicated under these criteria with 800,000 of the 1.8 million cancers each year in the US. That assumes an etiological fraction of 1. Look at the different models we've talked about, mixed effects, robust, and panel models. They're all inverse probability weighted. So they're causal models, geospatial models, and you can put them together and find that 17 here of these birth defects are geospatially linked. Assuming an etiological fraction exposed as the etiological fraction, you can work out these case numbers. 200,000, that's 8% of the cancers in the US, 152,000. Are cannabinoid linked. So we've talked about cannabinoid neurotoxicity and genotoxicity, causally established in autism, exponential growth, cannabis-driven, mental illness, young adults, cannabis-driven, 42 of 62 birth defects, cannabis-driven, 19 of 34 cancers, including breast and prostate, the commonest cancers. It's worse than alcohol and tobacco combined. In fact, in some of the analysis, it's actually worse, twice as bad as those. There's a big jump from the 4th to 5th quintile, which is very worrying because it suggests that you can hit like a speed bump where things take off in terms of toxicity. It's not just THC that's implicated. Cannabidiol, cannabigerol, cannabivarin, tetrahydrocannabivarin, and cannabinol are all implicated as well. And we've looked at multiple of models, causal models. In terms of work to be done in the future, it'd be great to see a combination of inverse probability and geospatial things. We need a continuous biomarker and more research in the area and more higher resolution spatial temporal. This is some of the references that we've done, and thank you for your interest.
Thanks, Stuart. That's a terrific amount of information. I'll ask you to stop your screen share on your computer. And the reason we invited Stuart was because of the remarkable work that he's been doing with bringing together very large data sets. And you can see his excitement about being able to take forward the sciences around causal analysis. So we're really grateful. Stuart, I think that your screen is still sharing there. So I'll ask you to click on stop screen sharing, and we'll then be able to invite Julian. So you've heard from him and seen that the mechanisms of the effect, not just of the THC, but also many of these cannabinoids that are marketed to us as medicines, are actually very highly destructive genetically. We see birth defects linked here. We see cancers linked. For me, Stuart's work has been a game changer. I'm off the fence. I'm hoping many of you will get off the fence with this. We need to take some action. Ask Julian to come now and talk to us about his work on cannabis and vehicle accidents. So I welcome you, Julian, and welcome you to now share your screen and do your presentation.
Thank you, John. Thank you for putting this together. This is really great. Can you see my slides?
I can, thank you. They're presenting well.
All right, thank you. So my name is Julian Santaella-Tenorio. I'm going to be talking about recreational cannabis laws and road safety. And this is important because in the US, many states have enacted different laws, medical cannabis laws, and also 17 states have recreational cannabis laws. And in this new landscape, we see that there is growing concern about the effects that these laws may have, increasing marijuana use, but also increasing people driving under the influence of marijuana, and as well increase the number of fatalities due to accidents in the streets. And this is important because of the burden that this type of events put on society, on communities, family, and individuals. So we conducted a review and we saw three interesting things. And the first one is that over the past 20 years, the past year cannabis use, the prevalence of past year cannabis use has increased among those 18 and older, has remained pretty much stable among teens, but it has increased among adults. Also, the prevalence of daily or near daily cannabis use has more than doubled since 2002. And we know for sure that there is really good evidence from experimental studies that cannabis use can reduce driving performance by increasing reaction times and also decreasing visual surge. And the other thing that we know because of all these experiments is that cannabis plus alcohol or other drugs can increase the levels of impairment. So we wanted to know what are the effects of recreational cannabis laws on traffic fatalities, because recreational cannabis laws can greatly impact the availability and the use of cannabis in a population. So among different papers that we found, two papers by Hansen et al. And another one that I will explain in a minute are really interesting because they show contrasting results. And the first one is by Hansen et al. Shows that in Colorado and Washington state, there was no effect of the implementation of recreational cannabis laws on traffic fatalities using a synthetic control method. And then Lane and Hall published this paper in addiction showing that using time series analysis that there was a steep increase right after the implementation of these laws, followed by a subsequent reduction over time. So to better or to reconcile these findings from these two studies, we decided to do our own study using a methodology with synthetic control. And we also wanted to focus on Colorado and Washington state because these are the two states that first enacted these kind of laws in the US. And therefore you can get a cleaner estimate of these effects without worrying about contamination or spillover effects from other states that have implemented this law. And our outcome was traffic fatalities from the fatality analysis report system from 2005 to 2017. And our exposure was the implementation of recreational laws, which happened in 2014 for both states. We used a synthetic control approach, which is a quasi-experimental design to compare observed versus expected outcomes for the exposed states. And basically what it's doing is trying to create or to identify the best control group based on a weighted combination of states without these laws that will track together with the trend for the exposed state, let's say for example Colorado in the pre-law period. And then with that you can see what happened after the law was implemented with the observed data for Colorado, for example, with what would be expected had Colorado not enacted this law, which can be thought as the counterfactual. And we used this identification of the best synthetic control for Colorado and Washington state using a vector of different variables that are thought as confounders of this association. And these are variables that we use and that have been used in many papers in previous research on road safety. And we also use a vector of the rate of traffic fatalities in 2005, 2009, and 2013. We also use permutation-based tests, which quantify the uncertainty of the effect estimates. And you can think about it as trying to identify a p-value as many other statistical studies would use in research. So let me take you to the results. This is for Colorado. In blue, you see the average rates for all control states when we use all control states. But what is interesting here is the brown line, the orange line is the rate for traffic fatalities for Colorado. And you see the black line is the synthetic Colorado that we created for Colorado. So you see that they track together pretty well before the law is implemented. And then after 2014, you see that they kind of like become different. And the probability for these findings is 0.047, which is below the traditional 0.05 threshold value. And we see it also with this model that allows to calculate the excess deaths that we expect in every year compared to the synthetic control. And we see that for 2014, there are 37 excess deaths of the 488 fatalities, which represent 7.6% of all deaths occurring in that year in Colorado. And that proportion increases all the way up to 19% in 2017, with 123 excess deaths of the 648 seen in that year. We also see that for Washington State, there's a different type of result. So we see that the synthetic Washington also tracks together really well with the actual rates for Washington State before the law is implemented, and continue to be pretty similar afterwards. And the probability for these findings is 0.67. So what can we think about these findings? Well, there's obviously a strong effect in Colorado, but no effect in Washington State. And that those heterogeneous effects could be, we think, explained by the difference between the two states, the ways in which these laws were implemented in both states. That includes differences in purchasing limits, sales taxes, and ability to grow cannabis at home. And when we look at the store density in 2018, we see that the store density in Colorado was 3 times the one in Washington State, which increases the availability of cannabis and can increase the use of cannabis. So this data from NSDU, from SAMHSA, and you can see that the prevalence of past month cannabis use increased in Colorado from 2012 to 2015 among adults. But in contrast, we don't see that in Washington State. In fact, we see a reduction in the prevalence of past month cannabis use. Another hypothesis that was originally explained by Lane and Hall is that cannabis tourism may be playing an important role in Colorado and not so much in Washington State. And this because Colorado didn't have any states that had similar laws. So that can create a situation in which many people from these other states go into Colorado to buy and use cannabis. Oregon, in contrast, had, Washington State, in contrast, had Oregon implementing a similar law in 2015. And the other neighbor is Canada, which in 2001 enacted medical cannabis laws and has pretty liberal policies regarding cannabis use. We also find evidence of increases in cannabis-related ER visits among out-of-state residents in Colorado, which tells something about that this kind of situation might be occurring in Colorado. Our findings are also consistent with increases in cannabis-related traffic deaths and also the percentage of injured patients with positive test results for cannabis. And all these evidence together kind of supports the hypothesis that these laws, recreational cannabis laws, can increase cannabis and the use of cannabis and other drugs simultaneously. And this can lead to risky behaviors such as driving under the influence, but also risky behaviors such as forgetting to use your seatbelt among passengers and also among drivers. To conclude, adverse unintended effects of these laws can be heterogeneous, as we saw in this study, and may depend on variations in the implementation of these laws. And also these findings suggest the need for policies, public health programs, and enforcement strategies that will prevent the unintended consequences of cannabis legalization. I would like to acknowledge the co-authors of this paper and also the NIH for funding our project. Thank you.
Thank you very much, Julian, for that careful analysis. And we're seeing clearly there, as you say, there's a bit of heterogeneity, and there may be some varied strategies that are needed in that area. Next, we have Dr. Jennifer Bailey, who we asked to come and present the case study that she's been observing what's happening in Washington State. And she's been interested particularly on looking at what's happening with young people. So I invite you to share your screen, Jen, and to do the next presentation. Thank you very much.
Thank you. Hello, everyone. Nice to quote unquote see you all. Thanks for joining us today. So as John said, I'm going to talk a little bit about what has been going on in Washington State. Since cannabis was legalized in 2012, we got a little preview in the last talk of some of those things that I'll touch on. Let's see. Okay, so in Washington State, the cannabis legalization legislation was called I-502. The I stands for initiative, which means it was actually passed by voter initiative in 2012. Sorry, I think I said 2012. Okay. Just very quickly, so sales in Washington State are privatized. It requires a permit. Cultivation and gifting are illegal. So, you know, lots of people share their marijuana with friends. That's technically a felony in Washington State. And I will say cultivation is permitted for folks with medical cards, but not just for non-medical users. We do have some fairly strict advertising restrictions in Washington, although those are being chipped away at by industry. Right now, we do not have any limits on the potency of cannabis concentrates, and I'll come back to that in a bit. The state does testing for THC concentration and also for contaminants like pesticides and molds and things like that. Sales of cannabis are taxed at the point of sale at a rate of 37% in Washington State. And written into the law originally, we had a fair amount of the money going to research, prevention, and treatment, of course, following the recent budget woes associated with COVID. The state has been pulling back some of that money just into the general state fund, which is a trend I think will probably continue. All right, so just some quick overviews of the cannabis environment in Washington State. As of 2021, we had 578 retail stores. That's 6.2 outlets per 100,000 people. Sales increased a whopping 605% between 2015 and 2020. And so to date in the state, we've had over $8 billion spent by consumers on cannabis products. And about $2.2 billion in excise taxes collected to date, and actually just under $48 million in last month alone was collected in cannabis taxes in Washington. According to budzoo.com, I don't know what they consider high quality cannabis flower, but that's a website that shows current cannabis prices in various markets. And according to that website, high quality cannabis flower costs just $12.44 per gram in Washington State, or about $37 per eighth ounce, which is very inexpensive. And so how's it going in Washington? Almost a decade into our legalization experiment. Several people were worried that the sky was going to fall. It didn't. However, in 2018, we know from state data that about 6% of adults drove high in Washington. That's not 6% of cannabis users, that's 6% of adults, 6% of drivers. So it's about a third of cannabis users report driving high, and that rate goes up to 60% when you talk about daily users. As we just heard in the prior talk, traffic fatalities did not increase in Washington State, but they did increase in other states and also in some analyses of the US overall, legalized states overall. We saw dramatic increases in calls to poison control centers for both adults and children. So for adults, this is accidental overdose, and for kids, of course, this is accidental ingestion, usually of edibles, which is sort of one of the more popular reasons for contact with control reasons. I shouldn't say popular, I should say common. We also saw an 18% increase in deaths by suicide among 15 to 24-year-olds. That works out to an additional just over 2 deaths per 100,000 people per year in Washington State following cannabis legalization. Rates of adult cannabis use and cannabis use disorder have increased, particularly, as time goes on. Post legalization, people are kind of getting more used to using cannabis, I think. It's a little unclear yet whether adolescent use has increased in Washington State. We've had some analyses of national data showing increases, and then others analyses of other national data showing no increase, and then yet more analyses of Washington State repeated cross-sectional data showing no increase. And so I want to share just a little bit with you about some work that I've been doing using longitudinal data from a sample of 426 families. About 80% of them are here in Washington, but many of the folks who aren't in Washington are either in Oregon or California, which also, of course, have legalized cannabis. And we have an accelerated longitudinal study. So we have followed 426 children for 10 years. 3 of those years were after legalization. And what the accelerated longitudinal design allows us to do is to compare kids from earlier birth cohorts who were between ages 10 and 19 before legalization. We can compare their cannabis use to the cannabis use among kids from more recent birth cohorts who were surveyed after cannabis legalization in Washington state. And so we want to see then, is the probability of past year cannabis use the same or different in these 2 groups of kids? Just very quickly, I know we're short on time, so I'm going to throw up the sample slide and say it's a diverse, gender balanced sample. And then here are some results of multi-level modeling of our repeated measures data. You can see what we've done here is arrayed the data by age of the child, and we've computed trajectories of cannabis use, the probability of cannabis use for the lower line, the blue solid line. That's based on data from kids who were these various ages before cannabis was legalized, and then the upper dotted red line, that shows the probability of past year cannabis use by age after legalization. And so that is a significant increase in our data. We also actually found that kids were more likely to use alcohol after cannabis legalization. As many of you know, I'm sure those 2 drugs are often used at the same time, either literally at the same time or by the same people. So that was a little bit disturbing because, of course, alcohol also has some pretty negative public health effects. So here are some what I think are take-home messages about the cannabis legalization experiment in Washington state. First of all, like I said earlier, the sky did not fall, but cannabis legalization had several negative public health impacts, including increased poisonings, youth deaths by suicide, and cannabis use disorder. Prices are down and potency and availability are up. And we know that these are major drivers of cannabis use. And so my personal expectation is that cannabis use rates will continue to rise in Washington state as prices remain low and potency and availability stay high. I also want to come back to this issue of potency, which I mentioned a little bit earlier. So there's, in the retail markets in Washington state, there are extremely high potency concentrates available, frequently in the range of 60 to 80% THC up to 99% THC. And we know very little about the health and behavioral impacts of high potency products. This is a real area of research need. There's some emerging research showing perhaps increased risk of cannabis use disorder, anxiety, social problems, and psychosis related to use of high potency products, but we really need to know more about that. I also want to emphasize that it's been a decade, but still we are kind of in the early days of cannabis legalization. An article I read about the US experience after alcohol prohibition ended was that it took about 40 years for levels of alcohol use to return to pre-prohibition levels. So I'm expecting that over the next couple of decades to come, cannabis use levels will sort of find their new level. And I also just want to say too, we have some legislation pending around potency, for example, in Washington state. And the lack of scientific evidence is really hamstringing those of us trying to inform decision makers and policymakers in Washington state, because we can't really give solid evidence. But industry, on the other hand, is ready to go in with very strong messages, and I think we are behind in the information. I hesitate to call it contest. I don't know what it is, but we're behind, whatever it is. All right, and that's all I have for today. So thank you so much for your attention.
Appreciate that, Jan. And as we saw there was some sort of confirmation of the mental health issues, but certainly I think the the availability, cheaper price, and the higher potency issues that we're sort of noting with alarm, particularly when we combine those with Stuart's finding of this number of things we may not have been aware of in terms of birth defects and cancers and some other issues. Now, we are on time. We've got an opportunity just to draw a breath at this stage, and if somebody would like to just ask any of the presenters that have talked about the potential effects, we'll start with one question. We will have 20 minutes at the end for more discussion, but if you wish, you can post into the chat anything that you might be curious about. If there is something, I'll ask. If not, we'll move on to begin to talk a bit about advocacy. Can't see a query there. And so I think we will have our presentations on advocacy, and I can see, Kevin, you've got your camera on there, so it's good to see you again, and I will invite you to do your presentation. Thank you very much for being here.
Great. Thanks, John. And I want to thank the panel, very distinguished panel. I'm often quoting many of your slides and data, and so it's great to see you here and to see the participants. I thought I could present a few slides about the things that we're looking at and we're concerned about, and then talk a bit about sort of what can be done, because I think what Jennifer just ended on, which is about we're behind the industry, couldn't have been said better. I mean, that is the problem. It's been the problem since day one. I mean, day one meaning, back in the 1990s, when this moved to circumvent the FDA and legitimize marijuana as medicine, which really came out of PR and activism. It didn't come out of science. That really was the beginning of this very quick roll to where we are now. And, we are behind in the science. We are behind in the advocacy. I mean, we're outgunned, we're outspent. It's very difficult. So I'm going to share with you a few slides here. And I actually titled it my latest book, because it just came out about a month ago. It's called Smokescreen: What the Marijuana Industry Doesn't Want You to Know, where I do an in-depth, really investigative analysis on the industry and what they have been doing, how they have run roughshod around public health, and kind of what we can do to get out of it, which I'll be talking about. Just some background. I have a PhD in public policy and did training at NDRI in New York and Yale and other places. But I really moved more into this space basically because I felt that there wasn't enough going on, that there was, that scientists were great, and we needed more of them, but we also really needed people to translate that language into messages that the public officials could understand. And so I served 3 different times at the White House, most recently in the Obama administration, writing the president's drug control strategy. But when I left, it was very clear that there was a huge void in the marijuana space from, really smart advocacy, not hyperbole, not overstating the case, but really a way that lawmakers could hear from affected voices, affected communities. And so Patrick Kennedy and I started SAM. We work with major organizations now, health organizations and others. But that's really the core of why we started Smart Approaches to Marijuana. And I think what's really important is we have to remember that maybe not in this group, but in the public discourse, we tend to conflate a lot of the issues, whether it's decriminalization, medicinal use, legalization. And it's really important to be clear about what we're talking about, because when we've done internal polling, even among people who voted for legalization measures in various states, we find that a huge proportion of them think they're voting for decriminalization, not legalization. And that has been, again, a purposeful PR move by the industry to conflate these issues. But in reality, they're, of course, very, very different policies. One of the things that really concerns us is the data coming from Colorado and other states showing that it's a smaller proportion of people that consume the large amounts of the volume of marijuana. And so we've not only seen a prevalence increase, and we've had, the percentage of past month users among marijuana users who are daily users is now about 4 times that of alcohol. They used to be sort of neck and neck, and then starting in the 1990s, marijuana was runaway in terms of the daily use, leading to basically 15 million daily users now among 12 years old. That's a unheard of number. That's a number we would not have been able to predict even 10 years ago. And so we're not only seeing the prevalence increase, we're seeing the intensity increase, the consumption levels increase, of course, the THC levels are off the charts. So it's really important to understand, again, it's not just prevalence that we're concerned about, it's consumption and intensity. What's incredible is that people also don't realize that, we're talking about treating it like alcohol. We have double the number of alcohol arrests in this country than we do marijuana. So we hear a lot about social justice, and I think it's important to bring that up. But really, that has not happened in a lot of these states that have legalized. We're still seeing arrests. You're still twice as likely to be arrested for marijuana and any other crime in places like Colorado if you're Black. We have not seen a reduction in prison populations. There's a lot more of this data on our website, but when you look at prison populations, what's happening, if there was a reduction, it may have been because of other drug policies, not marijuana, because of course people weren't serving prison time for smoking a joint. So we really have not seen that reduction. And we certainly haven't seen, people of color benefit from legalization. That's I think a huge myth we see is that, well, we're going to, make sure that people who are, have been targeted by police are now making money. That is not happening anywhere. And I interviewed many people in Smokescreen, which showed that. In fact, we're seeing, and it was good to hear earlier, our colleague from Colombia talk about the dispensaries. We're seeing that these communities, these pot shops are concentrating in communities of color, which we're very, very concerned with. Just a couple of things that have come across our desk we're also concerned with that we're bringing to the advocacy space, making sure that lawmakers understand. I think we can't understate that JEM pediatric study that came out in late March showing that marijuana addiction was double the prevalence than alcohol or cigarettes. So that's an incredible finding, given we don't have a lot, since some of the data from the late 1990s about the addictiveness of marijuana. Deb Hassan has done a great job, and her colleagues over there at Columbia, on looking at cannabis use disorder, which I think has been really interesting. But this by Nora and Wilson Compton and some others, finding this doubling of prevalence, regardless of the amount of marijuana you're using, whether it's a year, 2 years, et cetera, I think is an incredible finding that we're really talking to lawmakers about. When you look at the NISDA state estimates, we're seeing increases in youth annual use in various states as well. I think it's important to point that out. And of course, the mental health issues we have talked about. Every state is different in terms of data collection. So one of the ways we do advocacy is to make sure that states are on top of their data collection, which of course many states are not. But a little bit of digging, you find some incredible numbers. It's 20,000 homes with children who are not storing marijuana products safely. 30,000 homes. We have not talked about secondhand smoke far enough. This kind of advocacy, talking about the non-users and vulnerable populations like children, is very, very important and also very effective. And of course, the number one question from lawmakers, money, money, money. Well, they're not really making the money. They're finding that the projections are lower than they thought. They're finding that it's less than 1% of their budget. That is a real false promise in terms of what this is actually doing to help communities. I'm just highlighting one chapter in the book because I was very proud of it. It's the whistleblowers chapter, which is really kind of the centerpiece of the book, where I actually interview regulators in various states and people that have actually been in charge of marijuana policy in various states who have left for whatever reason, but are essentially saying that they have not been able to regulate this at all. This idea that legalization means regulation. Again, I think a lot of people think that it does, but when you dig deep, when you talk to people who've actually been there, when you look at the data on laboratories and when you look at the data on pesticides and molds and these kinds of things, we are not seeing the level of regulation that we might hope and expect. I do think it's very important to talk about what I call the next frontier, because folks, when we talk about advocacy, we need to remember we're not really only talking about marijuana. We are talking about heroin, cocaine, and other drugs being offered as part of, sometimes called a safe supply. I happen to be in British Columbia right now, which is really, British Columbia is the home to the worst opioid epidemic in North America, which again, is an incredible statistic when you compare that to a state like West Virginia that has borne the brunt. But BC beats out all of those communities in the United States in terms of death rate, in terms of the harm rate, and yet they're sort of doubling down on these kinds of policies. We really have to understand that this doesn't end with marijuana. We're talking psychedelics. Jeffrey Lieberman, the head of Columbia Psychiatry, and I just debated Rick Doblin the other day. And now it's about psychedelics and hallucinogens. And, there may be some medical value in some limited, forms, and we need to do that research for sure. Actually, I wish NIH would fund that research rather than, philanthropists that have an interest. But that is very different. Again, going back to the first slide of the different buckets, that is very different than medical research and legalization. So we have a lot more on our website. Essentially, I think the key points is to make sure we are translating knowledge into language that people can understand. It's really important that we keep writing the op-eds, keep writing the letters to the editor. And the final thing I'll say is, which kind of runs against my inclination as a PhD, and probably against the grain of all of us who are doing some research, is stories matter a lot. Stories matter a lot. And there's an old quote that says, the death of one soldier is a tragedy. The death of 10,000 is a mere statistic. Unfortunately, on the statistics race, we can have every statistic we want, but if we don't have the stories, the faces of who this is affecting, the mom whose kid, died by suicide and left the note saying marijuana made me do it, those kinds of chilling, unfortunate stories, I don't think we're going to gain much headway in reeling this in. So we have to bring those stories to bear. Thank you.
Thank you. Always a pleasure to hear your talk, Kevin, and you always present things that run in such a way that we don't hear these things in the other media. So it's actually really important. Now, Shane, would you just like to turn your video on for a second? I'm going to, so this is Shane, and do you like to give a brief introduction before I play your piece, Shane?
Certainly. Thank you for the opportunity to be here. And honestly, I've felt a very small fish in a very big pond. So I've been very impressed with what's been delivered so far. And again, always good to be with people of quality. Dalgarno Institute prepared a video clip of something we did last year, so it'll explain itself. But the Dalgarno Institute's a very, very long-standing, but very, very small grassroots public interest education, advocacy and resourcing group in Australia. We work out of Victoria, but we work nationally, and we have international engagement as well. Again, very small and very underfunded, as Kevin's just made very clear. It's one of the biggest issues we have. But what I've done is prepared something prior to what we did in 2020 as an advocacy campaign to try and get ahead of this in Australia a little bit. So John will share that video with us, and thank you again for the opportunity to be here.
Thank you for that, Shane. I'll now play this video. And
good morning. My name is Shane Varcoe. I'm the Executive Director of the Dalgarno Institute. Our motto is over 150 years of minimising harm by maximising prevention. Well, today's subject matter is around a campaign project strategy we implemented in 2020, the Cannabis Conundrum Tour. This national advocacy strategy was conducted throughout the year. The purpose for this whole issue around the cannabis pushback is creating awareness for the community and for community leaders, as well as exposing misinformation around this very misunderstood product. So phase one was foundational. So we go back nearly a decade. We were not only acutely aware of the now cannabis promotion strategy, but the emerging liberalisation momentum that was going to be coming down under. So we wanted to get ahead of that. And 6 years ago, we set up the Cannabis Conundrum web platform, which commenced information collecting and deploying a protocol into our networks and our growing social media platforms. We are a very small not-for-profit, so consistency and monotonous regularity of promotion were key. Collect, post, and broadcast, and driving people back to our websites. We used already existing and well-developed resources in the international space, including SAM, the Cannabis Support Australia, Smart Colorado, and skunk sense. The idea of this foundational platform was to monitor information streams and challenge misinformation and promote strong evidence-based research, challenging the prevailing pop culture narrative that was emerging that weed is now relatively harmless, and even medicine, which is only a new emergence in the last 3 years in Australia. We added to the Conundrum platform a cannabis as medicine, which focuses specifically on looking at cannabis as medicine and looking at all the issues around that, and created a cannabis library alongside the article posts that specifically hosted peer-reviewed and published evidence on the multiple harms of this now completely unnatural plant, as well as challenging the emotive, embellished or utterly faux claims of the therapeutic capacities of the plant. So why do we do this? In addition to what we've just mentioned, there existed no intentional, clear public voice of opposition and to the growing propaganda of cannabis. Yes, there are groups and great groups we collaborate with that were making noises, but there was no national focus. Profile the prevention and demand reduction sector, bring key stakeholders in the sector into the public light, get a voice of objection into the public square before we were overrun, create awareness around the many concerns and harms of cannabis, and plant a flag of warning in regard to the many public health and community risks, as well as sound an alert on need for protective and properly researched policies to avoid or at least minimise many of the disasters emerging in the US. So phase 2, what we did, taking it on the road. So essentially we're going to have a national tour where we're going to take cannabis experts into the marketplace, into every sector. So we set up our tour into key states with a priority focus on state and federal politicians and policymakers. We recruited 2 clinician experts on cannabis impact in the US, Dr. Karen Randall and Lynn Reimer. The international component added value to the campaign, unquestionable clinical and subject matter expertise, along with experience in this policy experimental disaster. In key cities, we conducted public meetings using very limited local networks to promote and attend, endeavouring to get on-ground advocates to contact key stakeholders and media outlets, with limited success, unfortunately. Simultaneously, have personal and group meetings with politicians and policymakers, advisors on the public health, mental health, environmental, community, productivity harms of the drug, but also focused on the failed policies enacted in the US. So just excerpts from the report of the overview. We had a budget around 61,000. We looked for funding for 50. We only got 3. Our outgoings in the end, not including staff costs and on-costs, was 32,000. So with frugality, we managed, and sacrificial collaboration, we managed to come in under budget, but still out of pocket quite considerably. If I look at the overview here, initially we had proposed 11 meetings, public meetings. We cancelled 5. 2 had non-attendance. In the end, total intended was 15, but we held only 9. Total requests made to politicians, 76 politicians were approached. That's quite a considerable number, with some really good inside takes on that. No replies from 35, unavailable was 28. Originally we had yes, 13 said yes. Additional meetings ended up becoming 9, so we had 22 in all across different states, which is quite successful in that sense. What we could have done better, look, there's a lot of comments here. All of them essentially were at the same issue. We needed, in short, to have better, clearer and more consistent communication of our offerings and our expectations of our stakeholders on the ground. We certainly did that with politicians. It was a relentless barrage of pursuit of them. But on the ground, we could have done better in our communications. That was a failing in our report. A conclusion from the report, our shortcomings notwithstanding, and we do not diminish the impact of them, the tour was a success in the seed sowing and strategic deposit context. Our disappointment with public turnouts is not really a reflection of our efforts, as we understand from both previous public forays and the experiences of the project lead, politically engaged, that turnouts on marginal issues are always poor. After that tour, we implemented what we called the next step was the Cannabis Conundrum Communique, which was a direct mail-out communication to all the stakeholders, the people we engaged, including politicians during that time. So every month they got a newsletter about particular issues. But also we bookended the tour, which took up all of February. We implemented a webinar, a national webinar in October, the Cannabis Policy and Your Community, What is Best Practice? We bookended it, as I said, at the end of the year, and we brought in 4 subject matter experts, 2 Australian professors, as well as 2 clinicians from the US. A lot of gatekeepers, unfortunately now, due to certain demographics, which I won't go any further into that, exposing who that or they may be, but those gatekeepers tend to push back hard the gatekeepers are more leaning into the pro-drug space, so the politicians we're not getting access to them, and the data we are promoting is not getting through. Rusted on drug policy bureaucracy. Unfortunately, harm reduction has got a huge traction in this country, 35 years of misuse of our harm minimisation policy. So they're rusted on in that whole harm reduction space. So primary prevention and demand reduction really are quite foreign to a lot of these people, or they don't see it as worthwhile, even though it has a high priority in the national drug strategy. Last 2 years, we've seen a shift in the media now that's cannabis compliant and people are banging the drum, particularly because the medical marijuana has taken over. Our actions are a continual approach to key political stakeholders. We had letter writing, meetings and communications, greater strategic collaboration within the sector. We're working together with other groups and promoting their work as well, educating and mobilising the communities to get them on board to understand the issue, and more resources are needed. The cannabis conundrum continues. Ongoing advocacy is another platform added to our already significant online offering, and this is a really good resource for both the public as well as for politicians and policymakers. And we've added the Cannabis Conundrum blog. This is a vehicle to engage regularly for broadcasting commentary and addressing media or other messaging promotions of cannabis liberalisation. Questions and answers. Thank you for listening today.
So we thank you very much for that, for preparing that, Shane. And now we do have time for some discussion. So I'll ask the panelists to turn on their videos. Thank you very much. And we might start, Stuart, if you could turn on yours as well. Yeah, so I suppose that with looking at many of the issues, I might just start by saying, Kevin, do you think that it seems that it's not just information that we need? So I guess that as when we look at ourselves here in the Society for Prevention Research, we're trying to do the right research, but we also do have a strong advocacy position. You're obviously quite experienced with advocacy, and we can see from what Shane's done that some small organisations sometimes can actually have a voice. But what is your sort of sense at the moment of how we might be able to be of some assistance in this work as an organisation?
No, I appreciate that question. Thank you. You know, again, there's always more research we need to get done. I mean, we could talk about secondhand smoke. We could talk about thirdhand smoke. We could talk about the 99% THC dabs that are becoming so common. All of that, you know, suffers from a lack of research. However, we have enough to be able to, you know, make recommendations and talk about, you know, what would make sense in terms of policy. And, you know, I think that because we have enough, we have to take action on it. One way to do it is, you know, to partner, and we'd be very happy to partner with the society, you know, from the SAM perspective, to partner and really look at, you know, what states are key, what federal officials are key to talk to, because I don't think that, for example, the Office of National Drug Control Policy now is hearing from a lot of scientific groups about this issue. They're hearing of them about opioids all the time because there's a lot of funding for opioids. I mean, who's in favor of promoting opioids? I mean, that, you know, that's not happening. So that's a very safe thing, and a lot of organizations like the American Society of Addiction Medicine, they've gone forward with that, but they haven't gone forward on the marijuana stuff. We feel like sometimes we're dragging people along, or we're the only ones. So this is very welcome news, and I think there could be many ways, in particular with the new administration in Washington, to be able to, you know, have your voice heard.
Thank you for that. So yeah, it does sound like we need to think about following up with some clearer statement, if we could do that. And it might well be that we are ready for the panel of people perhaps who have presented today could form the basis of a paper that we perhaps go to prevention science with as a review. And because the society does do these sorts of activities often in various advocacy areas. And I do think with, as I say, Stuart's new information places us in a position where we perhaps could think about doing that. And then again, those are placed on the website, and those position papers, they often do have to go through the board. So that would be, I'd be interested in leading something in that direction. Now, I'm told by our, that there is a poll today, which I wasn't aware of. So I'm going to look for that poll. Let's have a look here. All right. This is the poll that is going to be on the quality of the session, which we'll put out at the end. So just having a look at what that is. So that's fine. We still have some time to run before that. I'll run that poll at the very end. I suppose going back to some of what we've heard today, Julian, you mentioned that obviously the type of work you're doing, where it's sometimes the issues are such that there is variation, I guess, across the states in what some of the harms might be. But do you have any further work that you're aware of that's occurring in the road research area? You mentioned that there seems to be some clearer trends when we look at driving intoxicated and risky driving, but perhaps not so clear with fatalities. But they are, you are able to demonstrate fatalities in some contexts, but not in others. Yeah,
thank you for that question, John. I think it's fascinating the heterogeneous effects that we see. And another paper by Magdalena Sardá that was published in JAMA was also talking about like some differences in the prevalence of past month and past year use among teens in the different states that have enacted these laws. And you see these heterogeneous effects that are somehow expected in a way, because there are many differences in the ways these laws are being implemented. Not like the few examples that I showed there in regards to this taxes, in regards to like whether or not you're allowed to grow plants in your own home, and the amount of dispensaries per capita that are available at the state level are just some of the few differences, but there are many. And one thing that I think is useful about this kind of research is that it's allowing you to see what kind of aspects of the law, of the way the law is implemented, may help increase the risk or work with the community to lower those risks associated with the implementation of these laws. So I think there are many things that can be obtained from this kind of analysis that will help policymakers to implement these laws in a much safer way for communities in that state or in a specific country. You mentioned something about the type of fatalities that are related to drivers testing positive for THC, for example, right? And our results were consistent with that. However, the issue with this kind of data is that cannabinoids can be stored in human tissue for up to 5 days. So an increase in this kind of data, for example, in the amount of drivers who have positive results, could just tell you something about the increase in the prevalence of cannabis use in a state, and not really telling you that the driver was under the influence of the drug when he or she died. So we're very careful with that kind of data, and it's also a problem with the emergency department data, because when people test positive for this in these tests, it might be that you're actually saying that the person has smoked in the past 5 days, but it's not really telling you that the person was smoking or had smoked in the past few hours. And that is an issue for law enforcement as well, because it's easier when you pull a car and you have a breathalyzer and you use it to test for the levels of alcohol in the blood in that person. Is reliable. It will tell you that the person just had drinks like a few hours ago. But with cannabis, it's totally different because of these issues. So I think for future research, and something that we need for sure, is having testing procedures and instruments that are more reliable, like the ones that we have for alcohol, for example.
Thanks for that, Julian. I might return to the question now of cannabis as medicine. And Stuart, Stuart, with your camera, could you just adjust that? We're only seeing half your face at the moment. Thank you. Yeah, Stuart, you've presented quite a few statistics that suggest that the cannabinoids that are presented to us as medicines seem to actually be quite problematic, and they're not exempt from the birth defects and some of the effects that we're seeing. You're showing sort of, I suppose, associations with potentially cancers as well, and autism. So a number of these concerns that are at the moment, I believe they're under the radar, that they're not, I'm not seeing a lot of public contest around these things. So you're showing quite high causal implications with in your analyses for those. Do you can you tell us a bit more about the issues there around these cannabinoids that are presented to us as medicines?
I think there's a couple of main points to make. Firstly, everybody knows that there have been a couple of clinical trials for pediatric epilepsy, refractory epilepsy, and cannabidiol is recommended as third or fourth line treatment in that situation where it's not responding to other drugs. But there is an absence of clinical trials for the dozens of other indications which cannabis is proposed. As we heard earlier very correctly, it's a publicity stunt. It's not a result of medical science in the normal FDA progression of drugs to market that occurs. The other thing that's happened, if you go to clinicaltrials.gov, you'll see there's literally thousands and thousands of studies of cannabinoids for a lot of these indications underway, and yet there seems, to my understanding of it, there's very little coming out of that therapeutic pipeline. So that's fascinating for a number of reasons. Firstly, in the normal course of drug development, what normally happens is that if a drug fails a trial, it falls over. But with cannabis, as you say, there's this big popular or cultural push behind it. So it seems to be progressing. But, and it is obviously true that cannabinoids are a very important body system, and it's likely that therapeutics will emerge from that research. But at this point, for the simple things that cannabis, THC, the clinical studies are not looking very promising. That's my understanding. So I think in the risk benefit equation, the benefits are grossly overstated. As we've heard, it's mainly a PR stunt. It's a media phenomenon. It's not based on science. That's an accurate assessment. That's not to say that therapeutics won't emerge from that pipeline. I think they will. But the other thing I heard from Canberra the other day is that there are clinical trials being conducted in this country, but they're not looking at genotoxicity, which is a terrible worry. That's the reason we have the modern regulatory system, is because of the thalidomide disaster in 1957. In fact, thalidomide never went to the US because it was blocked by the FDA. And as we've heard already very correctly, the FDA process has been circumvented by the cannabis publicity machine. But cannabis has been known to be genotoxic since the 1960s. And here we are. So everything that we know, I mean, so much of the research, I mean, in any scientific field, there's always articles on both sides. So you have to look at the best quality articles and what's on balance of evidence, what you think. But the genotoxicity has been established for that year. And in the recent years, there have been sophisticated epigenetic studies, for example, and multi-generational studies looking at somatic cells, sperm, the F1 and F2 offspring that are coming out of that, parallels between rats and humans and similar changes. So it's a very consistent story. And that's why, of course, we did our research, because the classical outcomes of genotoxicity are in birth defects and cancer. And so the question was, okay, there's this vast theoretical background of cannabis genotox. Are we seeing this in the field? And what we found, of course, overwhelmingly is, yes, we are. It's not related to all birth defects, but it is to a majority, at least the 62 that are tracked by CDC and the National Birth Defects Prevention Network. And it's not related to all cancers in the same way that tobacco is not related to all cancers, but it is related to many of the ones that we looked at. And we looked at about 90% of the US cancers in the US numbers. So we think between the neurotoxic, I'm very concerned. And see, the neurotoxicity, I'm a doctor, okay? So I talk to patients, and of course I'm fairly conservative. So I typically say that we're worried that 5 or 10% of the children who are exposed in utero, antenatally exposed, may have an adverse neurological outcome. And I've been severely berated by my patients who come from the high cannabis using areas in the city where I work here in Brisbane. And they say, no, doc, you know that's wrong. It's 50 to 70% of the heavily cannabis exposed kids are going to be affected. So you put those kind of statistics, which is on the ground, real world lived experience, and I'm hearing the same things from my colleagues in Colorado, together with the genotox, and you have a very different narrative from the one that we're getting through the popular press.
Right, thank you, Stuart. I'm getting a message here from the conference organisers that we're running now 4 minutes before we wind up, and I think they're quite keen that we finish on time. So I think what I'll do at this stage is I will I'll just ask if there is any other final comments that anybody would like to make. Shane, would you like to? Did you have something you want to say?
I just wanted to say, John, that this has been an incredibly important exercise, and thank you for putting it together and being a facilitator of that. So that's certainly from our side. Great.
Yeah, and I have to say that I have been increasingly moved in recent months by Stuart. A lot of what you've been producing has really caught my attention, and as I say, I'm pretty determined that we do take this forward. So I thank everybody, and I'll be looking and reaching out to the panel. Yeah, and so I'm now going to I'm going to present a poll, which is an evaluation really of the session, and I'll ask people, this is going to be asking you, what was the quality of this session? How would you rate the overall connection among the topic and the speakers? And how well did this session contribute to your understanding? So I'm going to just ask your indulgence. I'll launch the poll now and ask you, when it comes up on your screen, if you would answer these questions that you now see. So we'll then be able to get some sort of a sense of how we're going. So I'm seeing that there's 17 people available to vote on the poll, and you're doing a good job of doing this for us. So we always appreciate, I guess we're the scientists that do like a bit of evaluation. So I'm getting your poll results coming up here. So we're now at halfway, and people are participating, which we appreciate of you. And I have 70% that have polled now, so that's very good. Just a few more, getting a few posts there. So just the last few, if you are going to. And I will, at that point, I think we've shared the poll results. So we've had pretty good endorsement of what we've been doing. So we've got getting a good rate of excellence and good. So I'm pleased with that. How would you rate the overall connection? Excellent connection, 92% are rating it as excellent. How well did this session contribute to your understanding? It was excellent, according to 85%. Is this virtual model, how well did the technology features allow you to participate? And there we've sort of got some sort of ratings. Probably could do a bit better in terms of trying to get ourselves. And again, I do reach out to you all, and what I would say there is that it's been great to have you share online. It's obviously one of the things that we are facing in the pandemic is the lack of opportunities for us to be able to get together. But so I wish you well wherever you are trying to get through the pandemic. I thank those who were able to do the panel. And I'm going to close the session now. And I do sort of also acknowledge the huge work the panel have put in. That they had to get up early or late or whatever their times were, and also rehearsed yesterday. And I'll reach out to people on it. So I'll close now, and I wish you all well.
Thank you all. Thank you.